purpose of this meeting today is just give an overview. It's apparently the topic looks like that it is for the people who are going for oral exam, but actually this message is for every resident and everyone who is entering in the anesthesia residency, that how you should be studying or how you should be reading a topic, because usually up till now, till the time we reach the post graduation, we are reading individual subjects, okay, and unfortunately, in most part of the world, we don't have an integrative medicine as a subject, which help us correlating different subjects together. Okay, and majority of the people are in habit of reading one book or one notes, or they just want a prepared material, which by which they are covering everything in one page. Okay, so unfortunately, this is not true for especially for anesthesia, because anesthesia is a specialty in which it's very difficult to find a quality book which covers all the aspects, and this is the main reason people are unable to prepare the topics well, and then it becomes a difficulty for them to pass the exam, even if it is written in the form of true false MCQs, or if it is oral part, because they are unable to correlate the thing, because anesthesia care is like a motherly care. Okay, if you compare the services provided by a surgeon or services provided by anesthetist, you can compare the care which is provided by a mother or a father. Father also care, but the care of father is not like mother. So anesthetist is has to cover the all the aspects. Even for example, if a patient is in operation theater, even if during the positioning, he has to take care. This is not related to his skills as a doctor. Even it is just like you are able to hold the patient's neck, or hold the patient's hand, or hold the patient like this seems to be slightly non-technical thing, but actually this is also related to anesthetist, because if there is surgery going on in a prone position and anesthetist is not able to give proper care to that patient, that patient will end up in having some problem. Okay, so this is just an overview, and now I think we can start formally what I want to tell you. Can you all of you please mute yourself, because it's uh, please, all of you, please mute yourself. It's very distracting for everyone. Okay. So now I will start. If I just take an example of a scenario, uh, I will just write it here. Just a second, please. Okay, so this is a patient, a 35 years old female, going for laparoscopic cholecystectomy, and she is a known case of Myesthenia gravis. Okay, so what are the anesthesia concerns and how will you manage? Okay, so who will volunteer? Jamil, would you like to take the lead? Yes. Zishan, would you like to take the lead? Anyone who wants to volunteer? Just raise the hand. Jamil, are you listening to me? Nobody is volunteering. Zishan, would you like to volunteer?
Assalamualaikum, sir.
Walaikum assalam. Okay, so if we just take this scenario here, okay, and I
Sure.
would like you to fill in with this approach. So myasthenia gravis, if you just tell me what is myasthenia gravis, how will you fit it? Please, I'm really distracted by the people. Please mute, all of you, mute yourself, please. Okay. Yes, Zishan. Uh, what is what is the main category of myasthenia gravis?
So Myasthenia gravis is an autoimmune disease
Okay, so it is an
uh,
autoimmune disease. Okay, fine.
in which
It is incomplete. Autoimmune disease affecting.
affecting the acetylcholine receptors. There are autoantibodies against the acetylcholine receptors, due to which the acetylcholine receptors are reduced in number, the effective acetylcholine receptors.
Okay, so what the result? So main category will be autoimmune disease affecting neuromuscular system.
Neurovascular system, right?
Okay. It
Yes.
is the main. So the pathology, as you were telling, that the pathology is that it is a disease in which there is autoimmune destruction of the postsynaptic acetylcholine receptors. Okay. So is it affecting mainly the skeletal muscle or smooth muscle?
No, it affects the skeletal muscles mainly,
Skeletal
not the
muscles.
smooth
Okay.
muscle.
So now you can think that which group of muscles will be affected, like where will be the problem now lying in myasthenia gravis.
The facial muscles, our bulbar muscles, our respiratory muscles, our skeletal muscles of our limbs,
Okay, you have not told the most important muscles which are related to anesthetist.
muscles of the larynx and the respiratory tract
Muscle,
में वो सारे कौन?
no, muscles of the respiratory mechanics.
Yes, sir. I told it.
Okay. No, no, you told
Yes,
the
sir.
skeletal muscle, but you have to highlight that it is
Yes,
involving
sir.
the respiratory muscle because
Yes,
diaphragm is controlled by something else, but all other
yes, sir.
muscles are all controlled by. That's why the what will be the result that if you said bulbar weakness, mainly actually, this is very distracting for me. The person who is on not unmuting, I will have to remove it. Please take care. Please make the mic mute. Okay. So now if you just try to filter out that the main disease, the main problem which will be affecting in among these skeletal muscles mainly will be the respiratory muscles and
The
the bulbar
respiratory muscle.
muscles.
Yes, sir.
Rest, yes, yes, facial muscles are the problem of thalmoplegia, and these are the problem, but mainly related to us are respiratory muscles and bulbar muscles. Okay.
Yes,
So
sir.
now, if you just see that uh, how will you diagnose this disease, for example?
First of all, clinical suspicion.
Okay,
There would be family history of the patient and the way the patient presents. We have to have a high clinical suspicion.
there is
And then
no
among the invest,
there is no proper diagnostic test. Maybe some autoimmune antibodies may be positive. Okay, so usually it
yes,
is a
sir.
clinical diagnosis,
Yes,
and
sir.
on the basis of history, examination, and relevant, like as you told, that family history is involved in it, and the specific features. Okay, so this is one thing. I'm just giving example of myasthenia gravis, and now you have to fill in all the disease whatever you are reading in this way, and I
Yes,
guarantee you will never miss anything. Okay, so usually one of another test which is highlighted for the diagnosis of severity, estimating the severity. What will you do for evaluation of systems involved and estimating the
Yes.
severity of the disease? What things would you like to see?
Sir, the post-vital capacity of the patient.
Okay, forced vital capacity is one thing. What else?
And,
There may be history of if there is bulbar weakness, what happens?
yes, sir, but there's no test for it. It's a clinical, no? On
Yes, yes. So
examination, mostly the classification of its grades is on clinical center,
no,
examination findings and
no,
clinical.
no, you are absolutely right. But I'm just telling you that the problem of severity related to respiratory muscle will be related to the like breathing difficulty, dyspnea,
Yes,
or
yes,
you can quantify it with the force vital capacity spirometry, or there will be some associated tests. Okay, so
yes,
similarly, bulbar weakness, how can you pick it? What like how can you evaluate? There is, you can say that there are chances of like that
let's see
bulbar
the
involvement
gag
is there.
reflex and
Sorry.
cuff. We'll see for the gag reflex and cuff reflex.
Okay, what else? There is one important thing. There will be history of regurg. Okay,
Regurgitation.
regurg, like patient is eating and there is there because the bodyguard which is
I mean,
protecting
it's not
the
regurg, it's aspiration
patient will tell is
during
as
eating.
regurg. Okay,
Right.
patient will tell it. We are at the moment we are a step of evaluating. Okay, so
Yes.
now if you are evaluating a patient with myasthenia gravis, in addition to all other, your main focus will be on these things. Okay.
Yes.
Okay, so similarly, now if you come to the second step, system affected, all the FS system, but mainly the system affected will here will be airway, respiratory, mainly. Okay,
Yes.
but if there is involvement of other autoimmune disease, so there may be a question here as well as that what are other autoimmune diseases which are associated with myasthenia gravis?
Other autoimmune diseases, there are thyroid diseases, Hashimoto thyroiditis, Graves' disease, then
Arsenide.
what's the name? Gastroid. Okay.
I'm not. I even I
Yes,
cannot
that is an
recall, but you
autoimmune.
can say that there are some other autoimmune disease which are associated. We can
Yes.
recall because I'm just giving you an overview of how to target a disease when you are reading any topic, how to correlate it. Okay,
Yes.
so then significantly there is no significant effect on the other systems. Usually it is the respiratory like muscle weakness and
Yes.
the involvement of neurological. I forgot to write here neurological. I should also write neurological. Okay. Okay. So neurological and neuromuscular involvement. Okay. Then what else? At the end, looking for the optimization or targeting the reversible component of the disease. Okay, and here I because actually this is I just chalked down the top here this top point should be up. What are the medication for or any therapy which is going on? So what are the usual medication for myasthenia gravis?
So anticholinergics are given, vasostriction, and then other than that, steroids can be given, plasmapheresis, IV
Do you call
immunoglobulin,
them as anticholinergics or there is a better name? Anticholinergics is not a very good name
anticholinesterase,
for what you are. Anti
anticholinesterase.
Anticholinesterase. It is not
Yes.
anticholinergics. Anticholinergics is
Yes.
atropine. You are not giving
Yes.
atropine.
Sorry.
Okay.
Anticholinesterase.
So
Yes.
because these blunders, these are blunders in the exam. Okay,
Yes.
so anticholinesterase, not anticholinergics. So anticholinesterase, and then here you can at the same time when you are reading any topic, any disease, you can read about the mechanism of action. What is the mechanism of action of neostigmine or pyridostigmine?
Uh, it will stop the
Anyone, if anyone
It will
wants to add, just he or she can
stop
raise
the
the
action
hand.
of cholinesterase
The
enzyme.
I'm sorry. Yes. Yes, Zishan, you can unmute yourself, please. Zishan,
It
unmute yourself.
stops the Yes, sir. It stops the cholinesterase enzyme. It inhibits the
Oh,
cholinesterase enzyme, which
okay.
causes breakdown of acetylcholine.
So it reversibly inhibits the anticholinesterase because there is one irreversible. What is that?
Yes, sir.
This is how
Uh,
you drain your mind, and that's how if
yes,
you
sir.
have the concept, you will never forget the things. What is
Yes,
that
sir.
medication? Have you heard of organophosphorate poisoning?
Yes, sir.
So these are the irreversible. So they will result in cholinergic symptoms. Okay. So
Yes, sir.
what like new why we are not giving new stigmine? We are giving pyridostigmine.
The neostigmine is very short acting. Pyridostigmine is a bit long acting than that.
Okay.
But
What
even its
else?
half life is 4 hours.
What else?
What else? I think it's not available in oral form. Yeah,
Yes.
neostigmine is available in IV form only.
Yes. This is another important thing. Okay. So what else?
We missed a thing among the diagnosis of the diagnostic test
Yes.
for this Myasthenia gravis. It was the Tensile test.
Yes, what is Tensilon? You can discuss. They can ask you about during the diagnosis. I missed it at that time. I was asking you,
Hydrophonium
and then I
Tensilon
forget.
test.
So
Yes, sir.
it is the Tensilon test. It is to evaluate the effectiveness of the medication and whether you are overdosing or underdosing. Okay,
Yes.
so you can do it under control scenarios, and you will give what will be good. What will you be giving?
Uh, Hydrophonium is
hydrophonium,
given.
sir. Hydrophonium.
Okay, how you use it? Yes, Afira, you can speak out,
Ji, sir.
please. Yes.
Ji,
How
sir.
you do hydrophonium test, Densilon test? Okay, forget about are the problems which you can face. If, for example, if the patient was in a cholinergic crisis and you gave hydrophonium, what will happen? Yes, please. Yes, I think I was disconnected. So you can hear me now?
Ji, sir.
Okay, so I will just try. So, how will you do it, or what will happen if, for example, the patient was in cholinergic crisis and you gave this
Hydrophonium.
hydrophonium? What will happen?
Sir, I explained as when we give the hydrophonium, then if there is increase in the tidal volume on giving this hydrophonium, then we diagnose the patient with myasthenia crisis. And if tidal volume decreases before the previous value, then it can be labeled as cholinergic crisis.
Only tidal volume. For
Uh,
example, if the patient was in cholinergic crisis and you gave hydrophonium, what as anesthetist you should anticipate?
the patient other respiratory parameters can also
Only you are
be
only
worsened.
focusing on, you are only focusing on one thing. There is some very important thing
Yeah,
because
yes.
if you think that it is,
Respiratory.
sorry,
So the symptoms will worsen.
what symptom will worsen?
So respiratory symptoms will be worst, like tidal volume, inspiratory pressures will be.
Afira, Afira, I'm giving
Respiration.
just a second. Ju-
So
The,
salivation, the sludge symptoms, so there's a mnemonic for that. So I think the symptoms like salivation, lacrimation, etc., they will worsen.
listen, all three of you, please listen. You are missing a very important thing that you don't have to tell everything. Okay, you can you
okay.
are right that you said that the symptoms will be worsened. This is correct answer. The other thing you said lacrimation, but you are missing most important thing. What is the
Vital
most
capacity.
no what is the most important cholinergic symptom in this case, which can create a big problem. Even it can be a
Respiratory paralysis.
The salivation will increase the risk of aspiration.
just a second. Anyone else want to tell? Because unfortunately, you are
So
not able to answer.
bradycardia.
Bradycardia. Okay. So what is the most important cholinergic symptom? Is bradycardia. Patient can have cardiac arrest. Okay. Understand? So you are answering correctly. I'm not saying that you are answering, but you are only focusing on one thing: lacrimation and salivation and aspiration and respiration. You are not focusing on the other thing, which is more important. Okay. Somebody rose the hand, please. You can, if you want to speak out, please speak out. PAVS. What you
So
wanted
there
to say?
was there,
Just a second, Zishan. Let him speak. What, Mr. PAVS, what were you saying? You rose the hand. You want to say something? Okay. Okay. Yes, Zishan, you can continue. Yeah, Dr. Indrani, I think your connection is unstable. We are not able to listen to you. Okay, Afira, do you understand?
सर जी सर मुझे कंफ्यूजन है सर कि ब्रेडिकार्डिया
We,
का मतलब अगर
just a
आप
second,
एट्रोफोनियम से हाँ
Afira.
जी
Afira, I apologize.
जी
Please, there are some international speakers. Try to
जी
conversate in
जी
English
जी
only.
जी सर जी जी सर जी सर
Yes,
sure sir
please.
sir I want to know the explain I want to know the reason of bradycardia caused by hydrophonium so kindly please
What part
elaborate
of
this
what group of medication is it?
so this
Is
is
it
anticholinergic
and it's not anticholinergic?
anticholinesterase okay
Again, okay.
it
So
will it will
anything which
it will
is,
it will facilitate the acetylcholine that will cause the bradycardia
yes, okay.
yes
So when you are doing
parasympathetic
it, yes, one thing is apnea. You are absolutely right. The other thing you should also be knowing, and this is a basic concept, that whenever you are giving anything which is increasing the acetylcholine, it will cause the cholinergic symptoms or muscarinic. To be very specific in this
muscular
case, it will be muscarinic symptoms. Okay.
जी sir yes sir
So, sorry, cholinergic, both muscarinic and nicotinic. The respiratory weakness and this is because of their nicotinic symptom. Okay, and the muscarinic symptom is because of the effect on the heart and secretions. Okay, these are muscarinic symptoms. So this is what happens. Okay. So now we will just try to move on. So effect of medication. So this I'm just giving you an overview. You will fit all disease. Whatever disease you are reading, try to fit in this format, and then I guarantee you that you will not miss anything. Okay. So now if you just focus, coming back here, that medication you have to continue, you can convert it into IV if needed. And if what other medications than anticholinesterase these patients may be taking? What are the other medications? Yes, anyone please?
Sir,
Yes, doctors.
antibiotics they might be taking.
Antibiotics, they are something more important than that. It's an autoimmune disease. So what kind of medication and a patient who is having any autoimmune disease must may be taking?
Steroids.
Steroids. Okay. Patient may
oh
be
yeah,
taking steroids. Patient may be taking immunosuppressants.
yes sir.
Okay.
There is a therapy in cyclosporin.
Yes. So if the patient is taking steroids, your concern will be that you have to continue, and you have to give the stress dose opioids. Okay.
There's
You
a
have to
steroid.
give the steroid replacement. Okay. Steroid replacement. Okay. And what else? There will be multi-systemic effects of what? Immunosuppressants. Okay.
Emergent.
Usually renal problems, this one bone marrow problems. Okay, so this you should be keeping in mind. So the word medication, usually when people tell about this thing, they are only telling, I will take the history of medication. This is irrelevant word at the moment. If you are not telling the reason or effect, your answer is irrelevant. It will be considered as irrelevant. The examiner will be irritated. He will ask you what will be the effect of it. So if you tell the effect, they will not be able to catch you. Okay. So immunosuppressants, multisystemic effects, steroids, steroid replacement, and steroids effect. So you should be answering this way. Okay. So what will be the risk factors here? If you just consider here, is there any pulmonary risk here? Okay. Is there any pulmonary risk involved? There is
Yes, sir.
aspiration risk involved.
Yes,
There
sir.
will be PUND.
Aspiration, there is respiratory failure.
There is problem with the airway. Okay. So in addition to ASA 1, so standard 1, standard 2 monitoring, which monitoring would you like to have in this patient? We are considering myasthenia gravis. Okay. Neuromuscular monitoring. Okay. So and not really blood transfusion. It can be there if there is some coagulation problem, but usually these are the things which are involved. Okay. So pulmonary risk factors are chances of patient requiring post-operative ventilation, chances of patient having pneumonias. Okay. And these problems, this neuromuscular problem, because there is altered effect of the neuromuscular blocking agents which we are using. Okay. So whenever they are asking you any disease, you just scan your mind in this way. Okay. So similarly, Zishan, tell what are the factors, or anyone, please, any volunteer, if anyone wants to speak out, just raise the hand and I will give the chance. Okay. Because it is better to have interactive. So Zishan, what are the factors which in myasthenia gravis patient, which can lead to requirement of post-operative like ICU or post-operative ventilation? What are those factors?
Yes, sir. So there's a criteria for it. There are some 4 or 5 factors which we have to see. Number one is the duration of disease. If the duration of
Okay.
disease is more than 6 years,
Okay.
then the dose of anticholinesterase that the patient is taking, if he's taking more than 750 milligram
Okay.
per day, and then if the patient has some respiratory problem already undergoing a respiratory problem,
Like COPD.
if
Okay.
his vital, yes, sir. If his vital capacity is I think less than 2.9 liter,
Now
and
this is not a very good answer. You should be telling according to the weight,
weight 15 ml per kg.
less than 10 ml or 15 ml per kg. Okay. And there is one more thing. What
So
about the
blood
surgery?
loss more than
Sorry, I can't recall.
No,
1
no,
liter
no, 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 no,
and
no,
major
no,
surgeries.
no, 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 no. We are talking specifically about myasthenia gravis. Okay. So upper abdominal or thoracic surgeries. Okay. So disease duration, dose, COPD, vital capacity, and upper abdominal or thoracic surgery. Okay. So there is risk of aspiration because of bulbar weakness. Okay. PONV risk will be there. These risks will be we are covering at the moment one aspect. Okay. We will go to the surgical aspect and then I will tell you how to tune according to the surgery. Okay. So now we are just concluding here. So long-term complication is related to the disease progression, steroids, complication of medications, but it may be there. Like, for example, if there is a patient with, for example, rheumatoid arthritis, so long-term problem will be related to the medications and everything. Okay. So I'm just giving an example and you can fit any disease into it. Like you can tune your mind. Okay. So now we have covered almost all things written here. Now I will come here. Effects of both disease as well as the treatment on anesthesia conduct. Steps like what will be the concerns related to pre-medication? Which pre-medication would you like to give in this patient? Yes. Who is telling? Afira?
Sir, these patients,
Yes, Ishan,
hello.
continue.
Sir, these patients can have a depression of respiratory system, so we should avoid any respiratory depression like benzodiazepines or opioids.
No,
Uh,
listen, avoidance is a very hard word. Okay, giving with caution.
Cautious,
This is
cautious.
one thing,
Okay,
and
okay.
actually, at the same time, they are at risk of aspiration. So, would you
Aspiration.
like to give prokinetic agent?
Yes, sir.
Okay, so this is
Yes, sir.
pre-medication, anxiolytic pre-medication give by caution. It's not absolutely contraindicated, so you can use it.
Yeah, yes, sir.
Cautious. Okay, monitoring we have already discussed that you use the word always, always. I will use in addition to standard 1 and standard 2 monitoring. In this case, it will be neuromuscular monitoring. And for example, if you are there is any other comorbidity which is indicating any other uh, invasive monitoring, like in invasive blood pressure or CVP or whatever, you can put it here. Okay. So what about the induction? How would you like to induce the patient with the myasthenia gravis?
Sir,
Sir,
Let
ideally,
us speak.
we should prefer a local anesthetic if there is any possibility, if procedure can be proceed under the local anesthesia, we will prefer this.
Okay. What
Okay.
else?
On other condition, if there is a not possibility with local anesthesia, then we can proceed with general anesthesia. Um, General anesthesia where we will adopt the rapid sequence induction, and we will do the induction um, with suxamethonium, and
Okay.
by using
Okay.
the cricoid pressure and Hanji.
And just a second. Just a second. You use the word local. I think better word is regional, not local. Okay.
Okay. Okay.
If the surgery can be done under regional anesthesia or nerve block, okay, so that will be one option. But just tell me one thing. You have a patient with myasthenia gravis and you are undergoing cesarean section under spinal anesthesia. What do you think? What can be the problems even with the regional in myasthenia gravis?
Sir, as patient is already with respiratory muscle weakness, so
Okay.
there may be risk of the high spinal and affecting the diaphragmatic muscles, and so we will
No,
be
no, Afira, please correct yourself. It is not the diaphragmatic muscles. Diaphragm is not,
respiratory.
yes, like abdominal muscles and intercostal muscles.
Okay, abdominal muscles and intercostal muscles weakness. So there may be the risk of the high spinal and affecting the muscle weakness more exaggerated. So I can use the epidural anesthesia and preferably general anesthesia.
Okay, so I tell you something. In the exam, try to use diplomatic words. If you say that regional is safer, yes, you can say, but you will say that if, for example, high involvement of abdominal or intercostal muscle occurs, this will create more problem. Because in GA, if you have given GA, you are able to control the airway. Here, the patient is at risk of aspiration, okay, and you have given spinal. And now, for
Right.
example, if you need to give any anzolysis or anything, this can create a problem. So you will not be 100% safe. So you will say that, yes, it can give you some advantages that you are avoiding the polypharmacy, you are avoiding the airway, but at the same time, if you are giving a regional anesthesia, which may involve the higher segments of spinal nerves, this still can create problem. Okay. So in this regard, both epidural or spinal can also create problem. Okay. You understand? So when you are telling about it, you have to you don't use closed-ended words. If you use closed-ended words, it is best. So now you cannot come back. You can say that I will evaluate the risk versus benefit and I will decide what is the best plan for that patient. Because there are some problems in regional anesthesia as well. Okay. So you use the word rapid sequence induction. So anything which may be related to muscle relaxants.
Sir,
Sir, there is resistance to the non-depolarizing depolarizing muscle relaxant, and there is more sensitivity to the uh, non-depolarizing muscle relaxant. So by keeping this in my mind, I will use the for rapid sequence induction. I can use the rocuronium, and
Okay. Just a second.
for maintenance.
No, no, just a second. Just a second. Let me correct few things. Number one, suxamethonium, if you are giving, there is resistance, and there are chances of when you are using high dose, there are chances of going into phase 2 block. Okay.
Phase 2 block.
So this is one thing you need to say. So you are saying you can say that if you are using, if you have the facility of Sugamedex, you can use rocuronium for modified rapid sequence induction. If you are using the word
Okay.
rocuronium, it is not rapid sequence induction. Remember,
Modified.
modified rapid sequence induction with rocuronium in the with the availability of Sugamedex. Otherwise, you will not use rocuronium because it's very sensitive and the effect will be too much prolonged. Okay. Yes, Ishan, what you were saying?
sir, Sir, actually, because of the unpredictable effects of muscle relaxants, both depolarizing and non-depolarizing, the most of the anesthetists prefer to use a technique where they don't have to use the muscle relaxants. They intubate the patient with the inhalational induction, with a deep planes of anesthesia with inhalational induction. Or the other approach can be with the total intravenous anesthesia also.
And you are absolutely right. But remember one thing, no technique is safe. Is there
No,
any problem related to an inhalational induction? It's
can't
not a
think
safe
of.
technique, remember.
Yes, sir.
Everyone does it, but you cannot defend it in this exam. Examiner will catch your neck.
Right.
So please don't always mention with closed ended. Again, I'm using the word closed ended. Inhalational induction is not at all safe in myasthenia gravis because the patient is already at risk of aspiration.
Yes, sir.
So it's not a very nice technique. You can say yes, it is one of the option, but that's the word you say that inhalation reduction also has risk of aspiration. Rapid sequence induction
Yes, sir.
also has the problem. So among them, rocuronium with sugammadex is I think safer approach as compared to other things. Okay. Even suxamethonium is not absolutely contraindicated. You can use it.
Yes, sir.
So
Welcome.
again, I say that induction agent, if you are using, you are saying total intravenous anesthesia. Yes, when you are using a mixed technique, you will achieve the intubating conditions. But again, if for example this patient is hypertensive, so the intubation reflex will become a big problem for you. Okay, so
Yes, sir.
these are practical things, but please don't overdo in the exam. If you use
Yes.
these words with conviction, no, inhalational reduction is safe. You cannot defend it. Okay.
Hmm.
So so this is one thing. So all of you are clear. All of you are with me, understanding.
Ji, sir.
Okay. So in induction, there is no safe technique. There is no safe anesthesia. You have to just overweigh the risk versus benefit, the surgical aspects, and then you will choose one technique which is suitable for that patient. If you are using this, these are the problem. If you are using this, these are the problem. That's how you will be telling. Okay. So maintenance, there is as you can monitor the neuromuscular blocking agents and the is there involvement of autonomic system in myasthenia gravis? Is there any incidence of autonomic involvement in this disease or no?
No, autonomic dysfunction? No.
Yes. Okay. Okay. So what about analgesia? So you will be making a plan for analgesia, multimodal analgesia, fluid therapy. In this case, this is important here. Okay. Recovery and post-op. You will be monitoring the patient in HDU. You will be resuming the anticholinesterase medications. You have to replace the steroids. You have to take care of the respiratory system. You have to be careful. Patient may start retaining CO2, and CO2 narcosis can occur. Aspiration risk is there. So this is how you will. Okay. So
Yes.
if you
So
are
there's also
again,
concern of reversal.
I'm sorry. Yes. Reversal.
There's also
Yes.
concern of reversal.
Reversal can be given. Reversal can be given because you are using the same medication. Neostigmine you can give. But the better technique for maintenance will be either to avoid, because now when
Yes.
the airway is secured, if you have good TIVA, okay, with remifentanil, okay, with dexmedetomidine, with lidocaine infusion, okay, you are giving a good, so you can avoid muscle relaxation in between, okay. Or if you need it, it is better to give 1 by 10 of which is the safest muscle relaxant in um, any patient. There is
That's the
no
tragedy.
cisatracurium, okay?
Kiron.
No, cisatracurium, okay? Atracurium is also, but the best one is cisatracurium, okay?
Yes.
So these are the things which are, so if you make a format and you prepare the disease in that format, believe me, you will not miss anything. I am repeating this word again and again. So the same thing which we have done: evaluation on the basis of history, examination and investigations, risk assessment and stratification and optimization. Like for example, if this patient needs any optimization, any if there is any like chest infection because of aspiration, you will treat it. If there is the symptoms are optimized by the use of or giving some steroids, the symptoms may improve, you will do it. Similarly, it is optimization is there in every patient if it is there, but this optimization will be depending on the surgical urgency. If surgical urgency is there, you have to proceed and you have to do the risk stratification. Yeah, like you can only do the reduce the risk factors, okay. So but this headings you, I just try to make, I was not able to in the correct scenario of Pakistan, I just emergency operating a prime minister, so I just try to make a mnemonic for it, okay. So evaluation, risk stratification and assessment, optimization, anticipation. What do you mean by anticipation? Like you are anticipating that this patient can have delayed recovery, this patient can have cholinergic crisis, that patient can have aspiration problems. So these are the anticipation of the complications, okay. And planning of all the anesthesia steps, as I told you: induction, maintenance, monitoring, recovery, fluid therapy, okay, and maintaining the homeostatic conditions. This is actually, it will come my best friends. Like what I always tell, that maintain hypoxia, maintain normothermia, normal temperature, volume, CO2, what else? Blood pressure, what else?
Hy- hy- avoid hypercarbia,
Yes,
acidosis, avoid
acid.
acidosis.
Okay, what
जनरल
else?
मेडिसिन यूनिफॉर्मல ப்ரிஃபர் பண்ணாங்க.
Okay, so I label them as my best friend: normothermia, normotension, normocarbia, normovolemia, sinus rhythm, okay, maintain preload and afterload, and avoid stress response, okay, and multimodal analgesia, okay. So these are my best friend, okay. So now we will go towards, so again, this is one way that you make it according to, because sometimes people are overstating it, and they are only trying to answer in pre-op, intra-op, I will divide. This does not look good. Okay, I will give you an example that if you are discussing a patient with a surgeon, will you tell like this, that's doctor, I am preparing pre-op, intra-op, post-op? No. So you have, this thing is just to help you out, and whatever you are doing preoperatively, you tell this at the first. Whatever you are anticipating intraoperatively, you tell that after that. Because if you use this word too much, it does not look very good. You use it but just to help yourself, not to just only make cover of it. Okay, so this is another way which you have to decide now. Patient demographics, a few words about it. What do you mean by demographics?
Sir,
The
age,
patient.
patient name, age, marital, married or unmarried.
Okay.
It's a social status.
Okay,
Um,
Ethnicity.
sorry.
Ethnicity.
Ethnicity. Okay. Height,
height,
Weight.
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 What else? Blood group.
Blood
Okay.
group.
And history, previous personal, like personal habits, smoking. Okay, alcoholism, addiction. Okay, what else?
Okay.
Any previous history
Uh,
related to anesthesia,
anesthesia,
surgery,
anesthesia history.
medical. Okay, but previous history,
Any
I'm only
comorbid
talking. And birth history. Okay,
vaccination, if there is a child vaccination history,
vaccination
transfusion
history,
history.
transfusion. So actually, you will not say these words again and again and again. Okay, you will just say that I will be focusing on the patient demographics, and if anything related to the patient which is significant, I will be looking into it. Okay, so
Okay.
this is just should be in your mind. In table viva, you don't need to tell it. Yes, in long case, yes. But in table viva, even if you are telling that there is a difference between a 55-year male versus female, that 55-year-old female, in addition to any condition which can occur in any male or female, there will be chances of having postmenopausal syndrome. Okay, patient may be taking hormone replacement therapy. So this is one thing which you will be only getting with the demographic data. Similarly, if you have a 35-year-old female and versus 35-year-old male, 35-year-old female can be pregnant in addition to whatever we are discussing. So these are the things, these are the small things which you should be looking at when you are only 55-year-old female. Your brain should be scanning what things can be there related to it. Okay. So this is how you will be focusing on the patient related problems. Then disease related concern we have already discussed, and shortly we will go into the surgery related problems. Okay. Okay, so surgery related, how you define it? What is urgent? There is difference between urgent, emergent, okay, and elective and planned. Do anyone knows about it?
Yes, sir. Yeah, sir. If there is uh, sir, you are talking about the surgery, emergency surgery, urgent surgery. Yeah, this
Yes,
is
surgical
about the
urgency.
condition.
There is, when we are in the ops floor and suddenly a resident of obstetric resident is coming screaming emergency, emergency, emergency. Okay, so on a
Uh,
lighter note, I
emergency.
asked that, is it your emergency or is it real emergency? Okay, so
Yes,
actually
yes.
the difference between emergent and urgent, actually usually we use it together. Okay, but there is minor difference. Like, for example, fetal bradycardia is an emergent, okay,
Emergency.
and
Yes.
appendix is urgent,
Urgent.
okay.
Appendectomy is also, appendicitis is also emergency, but for few minutes we can wait. So
No,
this is
hours.
categorized in urgency
Yeah.
hours.
No, emergency is within minutes.
Okay.
Urgent is within hours.
Within
Okay.
hours.
So, like emergent surgery, purely emergent surgery, for example, is firearm. You have to take the patient inside to control the bleeding. Otherwise, patient will die. Fetal bradycardia. If you don't open the abdomen, deliver the baby, baby will die. Okay. So these are actually true emergency. Otherwise, all others like intestinal obstruction is an urgent surgery. Okay. What about in obstructed inguinal hernia and incarcerated inguinal hernia? Okay. So these are actually urgent because if you
Urgent.
don't relieve, there is acute limb ischemia and they have to do the embolectomy. This is emergency. Okay. So like if you will not do it, there will be gangrene. Okay.
There will be gangrene, ischemia.
So and for example, now what is difference between elective and plan? Usually we use it together. So in the exam, don't confuse yourself. But I'm just explaining to you that it's the situation like that. If, for example, if you have a patient with appendix or you have a patient with intestinal obstruction, you can discuss with the surgeon and you can start the optimization. Within few hours, you have to take the patient. Like you can at least few minutes to start the IV line, IV fluids, and then you can take the patient to IV to OR. Okay. So similarly,
So this will be categorized in the planned
uh,
when we are preparing optimizing the patient.
no. Listen, planned surgery and elective surgery, like cosmetic surgery, they are elective surgery. Okay. Joint replacements, liposuction. Okay. Cosmetic surgery, these are purely elective surgeries. And
Okay.
what about cholecystectomy? Can we just do it as elective?
Planned.
It's a planned surgery. Okay. You can plan
It's
it for 1
planned.
week,
We have to
10
optimize the
days.
patient.
You can do it. Sorry. Actually, surgical urgency is not decided by you. Surgical urgency is decided by the surgeon. Surgeon will label it as elective or planned or whatever. Okay. Like no orthopedic surgery is elective. Remember one thing. Okay. Orthopedic surgery is always urgent because if you don't fix the fracture, there will be chances of embolism. Okay. There will be too much pain. There will be stress response. Patient will be in big trouble. So you cannot delay it. So this is an urgent surgery. Okay. So this is just to make you understand a little bit difference, but usually emergent and urgent are using together and elective and planned are used together. Okay. So this is the difference. So surgical urgency, then surgical risk. There is a classification of American Heart Association according to the surgical risk. Give few example of high risk surgery.
So high risk
Surgery
surgery.
includes vascular surgeries, abdominal thoracic surgeries,
No,
any
no. Zishan, please correct her.
So cardiac surgery, vascular surgeries, like on the major vessels,
Sorry.
and emergency
Yes.
surgery,
Okay. There is one more, liver transplant.
transplant surgeries. Yes.
Okay. Major vascular
or
surgeries.
or any surgery with the major fluid shift also,
No, this is
included to that.
intermediate risk, Jamil.
No, depends. No, major
but
surgery with
sir,
massive fluid
sir,
shift
uh,
included to that.
Okay.
it includes in the major surgery.
Yes.
Fluid
You are
shift.
right. You are right. Okay. Emergency surgery, especially in elderly patient. This is high risk surgery. Okay. So intermediate risk, body cavities. Laparotomy is intermediate risk surgery. Okay.
Yes,
Body cavity
intraperitoneal.
surgery, these are intermediate risk surgery. And head and neck surgery is also
Intermediate surgery.
Intermediate. What about
Yes.
breast?
Carotid
Orthopedic,
endarterectomy, also head and neck surgery, including
head
carotid
and neck,
endarterectomy.
orthopedic, prosthetic,
Any
thoracic surgery.
cavity opening, yes, cavity opening, any neurosurgery, thoracic cavity or abdominal cavity opening is also included to the.
So now the task is that I will just show you a possible list of the surgeries, and please try to prepare yourself, tune yourself. The common 15-20 surgeries which may be asked in the exam, you should be knowing usually what is the urgency, what is the surgical risk, what is the bleeding risk, any position required. That's what I have written. What is the usual duration? What is the level of incision required? Okay. What is the anesthesia option, analgesia options? Okay. What are the critical steps in that surgery? Okay. You understand? So now, for example, if we just put it, because in our scenario, it was 55-year-old, sorry, 35-year-old female for laparoscopic cholecystectomy. Okay. So now you understand what are they expecting from you? Now you can speak out that there are concerns related to 35-year-old female. There are concerns related to laparoscopic cholecystectomy. There are concerns related to
Yes.
myasthenia gravis. So in that they
Okay.
say, I will evaluate the patient and I will evaluate the severity and the systemic involvement of the patient with myasthenia gravis. I will see how much is the respiratory involvement and how much is bulbar involvement. In
So
addition to,
before
yes.
starting any case presentation like this, this is the myasthenia gravis patient. So the first starting sentences I will say, I will speak in front of examiner. So would be safe, like they say, you have explained right now. This is the case of myasthenia gravis, and I'm having uh, anesthetic problems regarding uh, pathological problems, anatomical problems, physiological problems. So kindly elaborate this few
No, I'm
starting
just telling you.
sentences regarding any.
No, listen. That's what I'm telling you. That, for example, if this question is being asked to me, that Dr. Zishan, you have a patient, 35-year-old female going for laparoscopic cholecystectomy, and she's a known case of myasthenia gravis. How will you proceed? So my answer will be that this patient is having myasthenia gravis. So my first target will be to see the severity and the systemic involvement of myasthenia gravis, because it can involve the respiratory system, it can involve the bulbar weakness. So patient might have might need to be evaluated in that regard. How much is the duration of the disease? How much new the same factors, because you don't have time to answer this question. You have 1 minute. What would you like to say in 1 minute? Just tell me. The words which I am telling you about myasthenia gravis will finish in 1 minute. You can tell that this patient duration, the factors which we discussed. The same way you can just that I will be looking at the disease duration. I will be looking at any coexisting pulmonary disease. I'll be looking like how much I will be evaluating with the vital capacity, okay, and functional reserve of the patient. So this will give me an idea where the patient stands or whether the patient needs any
Severe
optimization.
or mild.
Yes. And then the second thing, will be correlated with the surgery. This is sort of abdominal surgery. Okay. So this is one of the risk factors. And laparoscopic surgery, you can discuss with the surgeon how much time I can buy. For example, if you can, if the patient needs a little bit of optimization, I will go for the optimization. Okay. So you will use this word and then you will correlate with laparoscopic cholecystectomy, and you will rule out any pregnancy, because if the patient is pregnant, you will be taking care some of the things. So similarly, you will answer that this patient, I will be looking at the disease pathology progression and the organ involvement of in myasthenia gravis. I will be discussing with the surgeon how much is the urgency. If patient is having any sign of decompensation, I would refer the patient to the endocrinologist or internal medicine to optimize the patient so that the post-operative outcome will be improved. You will use this word, and then they will ask you how will you give anesthesia. Try this, because you never try this, because it is never written in any book. You tell me any
Yes,
book which
yes.
you tell me.
No, nothing.
Now you understand why I say manhus Morgan.
Yes, sir.
Manhus is a word in every language. I will say it manhus. Okay,
Yes, sir.
because
Understand.
this will never give you a vision to speak out like this. And then they with the self-explanatory, you know everything. You know the anesthesia induction steps, maintenance step, analgesia, fluid, neuromuscular monitoring. Now tell me, just take a deep breath and tell me, is it difficult to answer this question or easy?
Yes, sir. Inshallah, we will practice and definitely it will be easy.
Okay, so
But
this is the
yes, sir.
example that in this patient, if you want to highlight steroids, neuromuscular blockers, aspiration, okay, bulbar, you can just make buzzwords in one line for revision. Okay,
Yes.
so if we just fit the surgical aspect in this approach here, which I told that surgical, is it an urgent surgery? It is elective to planned surgery. You can discuss with the surgeon. Surgical risk, it is intermediate risk surgery. There is risk of bleeding while placing when they put the trocar. During the trocar insertion, it can rupture any viscera and it can cause bleeding or visceral damage. Then another thing together here will be risk of air embolism. Sorry, gas embolism. Okay, it will be actually gas embolism, that CO2 which they are insufflating can enter any major vessel. Okay, then what about position? Is there any problem related to the position while laparoscopy? There can be dislodgement of the tube. There can be endobronchial intubation. Okay, they because they are making head side up down. Okay, they are making a specific position for laparoscopy. So this is will be problems related to the position. You have to tuck the arm, or you have to place it in that it is not stretched. Then level of incision required because always whenever you are preparing a patient for laparoscopic surgery, you have to mentally prepare for open incision as well. Okay, because at any point of time they can open it. Am I right?
Yes, sir.
So what will be the level of anesthesia required for laparoscopic surgery? If you just want to give epidural, up till what range would you like to give? Zishan? Yes, Jamil?
Sir, can you repeat the question?
Sorry, sir. Actually, I was typing and requesting if somebody can elaborate the classification of myasthenia gravis by the severity wise,
Just a
class
second,
1,
Jamil.
class 2,
Actually, yes, you are absolutely right. But I will come back to it if we have time, because today
Yeah,
my
sure, sir.
aim was to give you people a view how to prepare any topic. Okay, so just hold on this question. At the moment, we will just try to finish this, and at the end, anything related to myasthenia gravis which we have missed, we will discuss. Okay.
Yeah, second thing also, just if anybody knows about the plasmapheresis and immunoglobulin properly with doses, can explain or share the knowledge. Yeah, these
Okay.
are my concerns. Thank you.
Okay. So, what will be the level of anesthesia required? Yes, Zishan, you were saying. Anyone else, if you want to speak out, please feel free to speak. I will be very happy to get all of you involved. Please, anyone. What level of epidural or, for example, what level will be required? Yes.
For a laparoscopic cholecystectomy, sir.
Yes.
Not sure, sir.
Agreed. 424.
I'm not sure. I said I'm not sure.
No, why you are not sure? Yes, anyone? Any comments? Afira?
Yes, sir. No,
That's why it can
sorry.
be thoracic, upper thoracic level, T1 to T4.
Is it because
It's
of
just
upper
random.
thoracic level? This T4 or what?
So, T4, up to T4,
Why?
because the position of the
Yes,
liver.
no, no. Let me give chance to Dr. Nashida Mahmood. Please tell. Yes, Dr. Nashida, you
Because of
know
pneumoperitoneum.
pneumoperitoneum, you are right, but again, still it is incomplete answer. It is because of mesentery.
Mesenteric stretching. Yes.
Okay, it is
Yeah.
because of peritoneum. Wherever peritoneum is involved, peritoneum involvement may take requirement up to T4 autonomic. That's why if someone asks you what level of anesthesia are you required for cesarean section, the incision is in the uterus, and you are telling that I want level of anesthesia up to T4. Why? This is because of the peritoneum. Okay, and that's why I am giving you another hint to recall this thing, that if you have a little bit, not you are not achieved the required level, when they have delivered the baby, up till that time patient will be comfortable, but when they are resuturing it or they are putting their hands to have the mopping, at that time patient became unstable. It is a sign that your block was not up to T4 autonomic. Okay, and another point I need to clarify at this time, you put your finger on the Xiphi sternum and you say T4. Xiphi sternum is T4 or T6?
T6.
So why you are saying
Nipple,
T4?
nipple there the level of T4.
No, no, you are right. But actually, when we are putting our finger on Xiphi sternum, it is T6 sensory level and T4 autonomic. Because autonomic is 2 segments higher, usually. And motor is 2 segment down, usually. So when we are talking about pain, we are talking about autonomic, usually. Okay. So we put our fingers towards Xiphi sternum and say we will have a level up to Xiphi sternum, but actually it is 2 segments above that is autonomic. So T4, and above T4 is called as high spinal. Okay. And if it is reaching the cervical, then it is total spinal. And how can you differentiate between total spinal and high spinal? Dr. Nashida, would you like to tell?
Sir, in total spinal, the patient will stop breathing and there will also be associated respiratory paralysis.
Okay, so can there be apnea?
Consciousness.
Yes, apnea, loss of consciousness, and
Loss of
bradycardia.
consciousness.
Let me please clarify this thing. Please just give me a second. Can a patient with high spinal, not total spinal, become acnic? Can or no?
Yes.
No. In high spinal, there is just bradycardia and hypotension.
No. You are right.
Bradycardia, hypotension, apnea.
Afira, just correct your concept. Even with high spinal, patient can become apneic. Why? Because of severe hypotension, there will be transient hypoperfusion of the brainstem and patient can go in apnea. But that apnea will be, listen, let me finish. Listen, let me finish. But this apnea will be transient, and as soon as you recover the blood pressure, the breathing will be resumed. But if it is not resumed, either there is a hypoxic injury or there is total spinal. Okay, now you speak out, please. What you were saying, now tell.
So I was saying, sir, that the first symptom will be the bradycardia and hypertension. Then it can be apnea. There will be
Listen,
apnea.
remember
But
one
in
thing. Remember one thing. If you are reading a book, you will get this answer. But practically speaking, the patient never follows a book. even practical conduct of anesthesia, even in the exam. Both things can occur. Both things can occur. Okay.
Okay.
So there is no, it is not a mandatory thing that bradycardia will occur first, and then
Okay.
when there, why there is severe, what happens? Because the sympathetic supply of the heart is from T1 to T4. This is called as cardioacceleratory fibers.
Cardiac.
When cardioacceleratory fibers are blocked, there is sudden decrease in the sympathetic supply of the heart. So not only bradycardia occurs, suddenly the cardiac output will vanish. It will be decreased because the heart is not able to pump. The sympathetic tone is not only for chronotropy, it is for inotropy, both of them. Am I right?
Yes, sir.
So it will occur simultaneously. So there will be severe hypotension, which can cause hypoperfusion, and patient can go in apnea. But this will be reversed. Okay, so this is just an associated topic which we discussed. So
Sir, one question, sir. Matlab, after how much time it will be reversed?
there is
Immediately or
no,
after?
listen, there is no fixed time for it. Okay, if you are talking about total spinal, till the time bupivacaine is metabolized, patient may remain.
It depends upon the dose, how much
Intermittent.
dose
Depend
you
on
given.
what is difference between now another because now we have opened this topic. Jamil, you just so I will not ask you. I will ask anyone. What is difference between the now third problem last? What is difference between local anesthesia, systemic toxicity, high spinal, and total spinal?
Local last is the local anesthetic toxicity caused by the injection directly into the vascular system vessels. So it will cause the symptoms like convulsions, tinnitus, oral numbness, and seizures, then causing the cardiovascular instability like arrhythmias, cardiac arrest.
Okay, so just tell me
And
now one thing. When we inject local anesthetic to any part of the body, okay, like we are giving it to spinal epidural, or we are doing local infiltration, or you are giving this one nerve block. So where it goes? From the place where we injected, where it goes?
sir, through regional anesthesia.
Yes, where it goes? It is actually absorbed in the blood. Okay.
Yes.
So it is
Yes.
not necessarily that you inject it in the vascular system. I just wanted to correct your statement that it is
Yes,
not
yes.
necessarily entering in the vascular system.
Into
It
the
is the
vessel. Yes.
absorption. It is the absorption, sudden
It's the
absorption.
absorption.
Okay. So if you
By
are
any
giving
route, by any route.
by any route, it is so
Any route.
because that is the concept of local anesthesia toxicity, that usually for bupivacaine it is more than 5 microgram per ml. If the levels are more than 5 microgram per ml, then the symptoms of local anesthesia systemic toxicity can occur, and this will be cardiac symptom may be occurring before the neurological system. Okay, and for lidocaine it is the other way around. Lidocaine, the neurological symptom can occur before cardiac symptoms, because the
And sir,
sorry,
how much dose can cause the last for lignopen, as bupivacaine is 5 micromole per ml toxic.
it is levels, not dose. It is blood level.
Okay.
I don't recall the lidocaine level. You can find it. I don't recall the lidocaine because it is usually higher levels. Because lidocaine we are giving IV, for analgesia as well. Even 1 to 1.5 milligram per kg infusion we are giving lidocaine. Okay, so that levels must be higher than bupivacaine. Bupivacaine safe dose by any route is 2 milligram per kg. People claim because in Morgan it is written 2 to 3 milligram, so it is last word for all of our poor residents, unfortunately. But if you read any reliable source, Naisura, you will find 2 milligram per kg. It is 2 milligram per kg, not exceeding that. For rocuronium, for this one ropivacaine, it is 2.5 milligram per kg. Okay.
Now, sir, now we
For
have to
lidocaine
see.
also more than 5 mics per ml also.
More than 5 mics per ml, the toxic levels.
Yes, sir. Yes, sir, for lidocaine also.
Okay, I don't remember this thing. Yes, Afira?
Then, sir, but in examination we have to speak like 2 milligram or 3 milligram dose of bupivacaine.
Milligram. 2
2.
milligram per kg.
Okay.
Don't be afraid. Don't be afraid. It is not the concept that Morgan is the last word. Examiners only read Morgan. It's not like that. Okay, so we are a little bit distracted, unfortunately. So level of anesthesia required we were discussing. Okay, and then possible anesthesia options, possible analgesia options, potential concerns and complications. What will be the concerns and complications in laparoscopic cholecystectomy? Concerns related to the trocar insertion, vascular or visceral damage, and then what about what else? Pneumoperitoneum.
Gas inflation, yes. Gas
Pneumoperitoneum.
inflation, pressure.
Listen, pneumoperitoneum pressure effects on cardiovascular and respiratory mechanics, endobronchial intubation, and then third is gradual absorption of CO2 is stimulating the sympathetic system, increasing the ICP, increasing the heart rate and everything. So these are three steps you can explain. Okay. One is trocar insertion, other is pneumoperitoneum, and third is the effect of the gradual absorption of CO2. Okay. So specific age group prone for that surgery. This is actually because I have just tried to tabulate just the main. So now I conclude this discussion. Okay, so we started that for any disease it is better to approach in this way. What is the main category, what is the main pathology, what are the possible problems, what are the organ system involved, how to evaluate the severity of that disease, how to evaluate the organ system involvement, and then you will be looking at how to optimize it. Then you will correlate with the surgical urgency, that how urgent is the surgery. You will correlate the surgical concerns and medical concerns, and then you will make a plan according to the condition of the patient, and you will be looking at all the steps like optimization, pre-medication, induction plan, monitoring plan, muscle relaxant plan, maintenance and inhalational anesthesia plan, and then multimodal analgesia, fluid therapy, and then recovery. So this is how you should be targeting any topic. Now, any questions before we finish? We can have a look on myasthenia gravis as well. Anyone has any question, please?
Again, sir, if somebody knows, can just share the classification of myasthenia gravis by severity, class 1, 2, 3, 4, I think, and 5. In class, what I remember that in class 1, there is minimum axial muscle weakness and there is no bulbar involvement.
Okay.
And in class 2, there is moderate
एक मिनट
axial
दीजिएगा मुझे.
muscle weakness,
Mhm.
and there might be bulbar involvement.
It is
And
written in the
Dr. Javed?
article.
Yes, on the ATOT article,
Grade,
the Osborne classification is given. In
grade
there are
1.
5 grades. Yes,
In
you
grade
don't know.
1, there is just only eyes involvement. In grade 2A, mild generalized myasthenia gravis responding well to therapy. 2B, moderate generalized myasthenia gravis responding less well. And grade 3, severe generalized disease. And grade 4, myasthenic crisis requiring the mechanical ventilation. These are 4 grades,
So
and
these are the gradings. These are the gradings what you are talking about. Okay. Okay.
yeah, this is the one. In some articles or maybe in some books there is
Remember one
some
thing, nobody will
classification
fail you
A,
on.
B.
I can write it on with our one of our teacher in medical college to say write down with red ink. So I am telling you, write down with red ink. Nobody will fail you on myasthenia gravis classification. This is a crap question. Another crap question I will tell you, which they are asking is what is ice pack test? What is ice pack test in myasthenia gravis? Anyone
Yes, it
knows?
was asked. It was asked to you in your Viva
Yes.
exam.
So I cannot never forget because I was looking at the examiner like a damn fool. What the hell you are asking me? What is ice pack test? Anyone knows about it? Ice pack test?
Ji, sir. So the ice
Yes.
pack test is done. We apply ice, cold ice or a cold pack on the ice, and for the myasthenic patient, the power of the muscles improves,
Mhm. Why?
and this is for a first.
Why it improves?
The reason is not known.
Very good.
I think the reason
So
is not
what
known.
are you? You just think about it. What is the main pathology? So pathology is the anticholinesterase. So there may be some relationship between the ice pack and the anticholinesterase enzyme. So actually, when you put the ice, anticholinesterase enzymes are inhibited and eye symptoms are improved. Okay.
Right, sir.
So this is a big thing which our examiners ask, and I salute to them. That I don't know why they ask these
Okay. The
questions.
second thing, sir, if somebody can share knowledge about plasmapheresis and immunoglobulin G treatment in myasthenia gravis, please, if anybody knows better.
Jamil, again, this is a minor question. In table viva, you don't have the margin of uh, going in details. What is the concept of plasmapheresis? What is plasmapheresis? Just tell me.
Just removal of the autoantibodies from the plasma, and it will improve the patient's conditions
So
before
that's it.
going to any
So
surgery.
if they
Yeah.
ask you in the question, ask you question in the exam, this is the answer. I don't think so. They are expecting more than that. What common diseases are being treated in that way? GB syndrome,
Yeah,
they do.
maybe syndrome also or any other autoimmune diseases also.
Okay. So this is, I don't think so. They are asking more than that. So don't worry about it. I actually I missed one of the aspect is thymectomy. Okay. Because thymectomy is a surgery which can occur for, which can be there for myasthenia gravis. Because there will be two scenarios. One is the surgery specific treatment surgery for that disease. This is one thing. And the other thing is the that disease patient for any other surgery. Okay. So thymectomy is being done, and that in that case it can be either via VATS or through open thoracotomy. Okay. So in that way, maybe even they require one lung ventilation if needed. Okay.
Yeah, yeah. Also, yeah. That's why, so now if they ask about the beds, then it's simple. There's no need to go for double human tube, and I think these patients can routinely extubate it. But if they go for open thymectomy, then there will be sternotomy and need double tube human tube insertion, post-op ICU bed we have to arrange.
Okay. So Jamil, what
Kindly
is the
please clear this. Sir, kindly please explain this. If we are using the VATS techniques, we will insert the single human ETT, and if we are
don't be confused. Afira, don't be confused. This is not, again I tell you, there are some points which are not failing points. Okay. VATs usually can be done with single human tube because it is not, they are not opening. Okay. So they
okay,
don't need it, they are doing it and by another technique. I'm not very expert in thoracic anesthesia, but that's what I know, that this will be the smart answer in this tech will be that you will be discussing with the surgeon. Okay.
okay.
So in the exam, if they are asking, believe me that if you have reached up to this question, you are already passed. In the table
Okay.
viva, remember one thing, for one specific topic, they have only 5 minutes. So just imagine how much they can ask you in 5 minutes. Just imagine. Okay.
Okay.
So, Jamil, what sort of immunity is provided by IV immunoglobulins?
Sorry, sir. Actually, was another call. Why immunoglobulin? We are getting passive immunity.
Passive immunity?
Yes, sir.
How? How?
Because already prepared the immunoglobulin and
Already prepared. You are
yes,
just injecting prepared IV immunoglobulins, so
yes, sir.
it can just tackle with the autoantibodies. Am I right or wrong?
Sir, please clear this concept. We are introducing the prepared antibodies, so this is enhancing the passive immunity in the host.
Jamil has very good concept about it. Please explain, Jamil. Yes, Jamil.
Yes, sir. Actually, I was another call. Okay, sir. What you asking about the passive
Just
immunity and
explain
active
that.
immunity?
Yes.
Actually, active immunity, like we getting the tetanus toxoid, where we stimulate our own immunity system to produce antibodies against that specific bacteria or some sort of agents, and it will activate our immune system. That's why it's called as active immunity. And when where we don't activate our own immunity system, it called as a passive immunity. Like we already prepared immunoglobulin transfused to the body, and it will not activate our immunity system. It called as a passive immunity, as
Okay.
getting
Okay.
Afira, you understand? One
Yes,
thing is
yes, sir, yes,
you are
sir.
bringing everything in the home and cooking it, and one thing is that you are bringing prepared. Okay, so
Yes,
this is difference
yes, yes,
between active immunity and passive immunity.
yes.
You are
Okay.
injecting a low power of the organism, and you are activating our defense mechanism, that is active immunity. Okay, so sometimes both active and passive immunity is required. That's why immunoglobulins, they are actually generalized, and they are being used in different conditions. Okay, so IV immunoglobulins or plasmapheresis will improve the symptom. Okay, but this will not be your decision. This will be the decision of the physician, when to do and when not to do. Your concern is to see any decompensation and any like thing which you can optimize. Okay. Similarly, you were asking about this thymectomy. Don't confuse yourself in it. Okay, because you will be asking which surgery, which incision they are giving. You see, it can be medial intestinotomy, it will be trans-cervical, trans-thoracic, sub-xiphoid. These all the approaches which they can use. So it will be for your side, you will have having the same similar concerns. Okay. I think we have covered the topic of myasthenia gravis in a nice way. Anything may be missed, you are all free to ask. But my main message for you, I will share this file to you people. Okay, that please have a printout, and whenever you are reading any disease, just try to fit it. And these I have just make some patient groups. I will suggest you to learn that because in the exam there will be a pediatric patient for any problem, but so that's why you should be knowing the anatomical, physiological and pharmacological changes in a pediatric patient, in an elderly patient, in a pregnant patient, obese patient. So because you will no exam will be finished without being asked these points. Okay, similarly, smoker, positioning related concerns, a diabetic patient or a hypertensive patient, general approach, how to deal a critical incidents. Okay, what else? Patient at risk of bleeding, how to deal with it. Patient at risk of thrombosis, how to deal with it. A septic patient. I have just made it a list. I will share with you. So some of the topics, they are already there in the YouTube channel. Okay. So because of Ramadan, I'm not able to take the regular classes daily. So tomorrow is also my off. So tomorrow same time we will discuss some other topic. Okay.
Okay, sir.
Any question before we finish? Okay, thank you very much. So same time, same time as today. Okay.
Okay, thank you, sir. Thanks.